So I am happy to introduce Kim Jenkins, and she is with One Oak, and she is an educational consultant. And so I I asked her to join us and just tell us a little bit about the services that they offer. And what I could say is clinically, and talking to my staff, that when we get to a point with a client where it just feels like in their environment as a teen, they no longer able to thrive, and as much individual work as we're trying to do, they're always still in an environment that everyone could be trying to do the right things, but it's just not working. And what happens then? And it's a very painful, hard point for a family and for the clients. And so really having people in the community that can help us and help the families is very helpful. So if you could just kind of give us a little bit of an understanding of what you guys do and when you step in to help families and teens.
Yeah. So I think that that's actually a great segue in. I would say, most of the families that we start working with are referred to us by outpatient therapists or psychiatrists. Sometimes other programs in hospitals where somebody, is stabilizing after a crisis or a suicide attempt or needing, some other form of stabilization. But our role as consultants and as clinical consultants is really helping to assess what are the needs of the clients that you guys are working with when it comes to what kind of programs might be most appropriate for them from a clinical perspective. As I was saying a little...
Define programs ranging from educational to clinical. What falls under the umbrella of programs?
Yeah, thank you. So most of the clients that we work with, I would say 95% of our clients, we are placing in therapeutic programs. Okay. We are called educational consultants. We're also called therapeutic consultants. I would say educationally, in terms of boarding school placements, that's a very small part of what we do. Okay. All of our clients that we're working with have some level of clinical need where they need to step into a higher level of care. That is often a residential treatment center, wilderness therapy programs, therapeutic boarding schools, young adult clinical programs. We often also will work with kids.
A young adult clinical program? What does that mean?
So programs that specifically work with the developmental age of a young adult, so sometimes between the ages of 18 to 25. Those are kids that might not necessarily do very well in a traditional adult residential program. So looking at more of the developmental cognitive issues that some of our clients present with to know, can they be in a group of adults that are 40 years old and still get their needs met, or do they need more of a cohort of young adults? And we look at that from a residential perspective sometimes, but we also look at it when we're looking at wilderness therapy placements and young adult transitional programs that may have more of an emphasis on getting kids back into college who have not been successful because of anxiety or because they've started using substances in school and have failed out their first or second semester, which we get a lot of those young adults. Right. But kind of going back to the types of programs that we work with a wide range, so everything from a 6-week assessment stabilization program for a kid who we need to really get diagnostic clarification. We need to get an updated neuropsychological evaluation. If there's a level of medical complexity that's going on that would impede a recommendation to a more traditional residential placement. I would say majority of the clients that we work with are clients where you guys as therapists are saying we don't really know where to send this person. And that's what we do. We're the ones who have been all over the country. We've traveled internationally. We've evaluated these programs. We know the clinicians. We know the leadership. We know who owns them. We know which programs are being bought out by large behavioral health companies. And we serve as the family's advocate through the entire process. So families have us to say, these are maybe 2 or 3 choices that we've had experiences with, that we've had success with a kid similar to yours. And we're going to hold your hand from start to finish throughout the entirety of that treatment process.
Is it okay if I ask you some of the questions that I think would be top of mind for
Yes.
my clinicians, certainly for me, so chances are for others as well? Age range.
Mm-hmm. Age range, we work with children as young as 7 or 8 that need residential placement. Those are children who are often adopted internationally, reactive attachment disorder, very complex and very behavioral. So those are hard cases for sure.
Okay.
I would say our sweet spot is kids between the ages of 11, like adolescents, 11 to 18. About 40% of our clients may be that young adult, 18 to 28. And then I do have a consultant that works in my team who really does specialize in adult placement. So maybe working with a parent of a child that we've been working with, or an adult who's really exploring addiction recovery, eating disorder recovery, and things like that.
Another question. In terms of teens sign off for doing these programs and willingness versus lack of willingness.
Yeah.
How does that work in terms of age and in terms of, for example, a program like Rogers, if the child or teen isn't willing to do it, then they can't do the residential. But what about someone who's unwilling? Can you come get the kid and get them where they need to be?
Yes.
And what ages can you do that until?
You can do that up to the age of 18.
Nice.
Yeah, so somebody has to be younger than 18 in order for us to have a therapeutic transport service.
So once they turn 18, you cannot do it.
You cannot do it. You can do we can do an intervention. Yeah.
Only if they're like a harm to their self or others.
Correct.
And they're 18 or older.
Correct. Yes.
But under 18, you can do a therapeutic transfer, what'd you call it?
Yeah, a therapeutic transport. So we work with a couple of different therapeutic transport services. Some people will call them escort services. The kids sometimes will call them goons. And they're often the ones who do kind of come in the middle of the night and help families, start that intervention process. It is not a setup where these two massive men come into the room in the middle of the night and tear kids out of the bed. It's much more of a collaborative and respectful process. Parents are involved in that process. But majority of the students and kids that I work with, they would not voluntarily go to a program, a wilderness program, or treatment. And it comes down to the conversation of safety. How do we keep kids safe? How do we get them the care that they need, even though they're going to be resistant?
Right.
And oftentimes for parents, it's the safest way to get kids into a treatment environment.
Definitely. And so for us, we kind of like to, your window is closing because unfortunately once they turn, like getting someone that you love, the care that will help them to thrive is going to get a lot harder. So your ability to get them what they need is, so it's just really important to keep that in mind.
We don't always have the luxury of starting with clients, before their 17th birthday. I will say, the longer we can have a kid in treatment before their 18th birthday, the more impact we're going to have on them. The more time we're going to have to work with to make sure that they're getting the clinical support and sometimes the academic support that they need. The closer they get to 18, the harder it is because even once you admit a kid who's 17 into a program, the age of majority in most states is 18. In Illinois, it's different. In Illinois, it's 12. So if we place a kid here, for example, at Rosecrans, that kid can walk out at the age of 12. They don't have, their parents don't have the ability to sign them in. Right. Which is what the limitation is here in the Midwest, which is why we end up working so frequently with programs that are out on the West Coast. So Utah, Idaho, Montana. And I'm happy in another conversation with anybody individually to field any of those questions about why are programs out West. There's a lot of publicity right now going on with Paris Hilton's documentary.
Oh,
yeah.
I mean, I think in our practice, we're really like so desperate looking for solutions such as, and we know these aren't scary words, but for
Mhm.
us, it's the complexity of how do we help our families get these kind of resources as rapidly to get everybody
Yeah.
healthy and healing as quickly as possible.
Mhm.
So I didn't even know that buzz going on, because I
Yeah.
this is really what as clinicians we're really looking for.
Mhm.
Um, uh, if you do when you said if it's an intervention, so if it's like an 18-year-old that's maybe punching walls and threatening family members, and
Mhm.
if the family's trying to decide, we don't necessarily want to call the police on them, but if that'll help them to be somewhere where at least we could then start getting them on a treatment path, can you be
Mhm.
involved at those conversations with families of, do we call that, like, how do we, what do we
Yeah.
do right now with this? Mm-hmm.
Yeah, yeah, we definitely can. And that is often, kind of when parents call us is at that crisis point. It doesn't always have to be,
Right.
but that's kind of our sweet spot. And, being able to jump in with a family and being able to put a plan in place for them really quickly. Best case scenario a lot of times is that if that young adult child or even adolescent child is at that point of being at very heightened risk of hurting themselves or hurting others, to look at hospitalization if we need to.
Right.
And then to have me looping in with the family from day one that that kid is in the hospital, so that I can work on getting a placement in place and having that kid go door to door
Right.
from the hospital to the airport on a plane to get them into that next treatment environment. So that there isn't time in between to kind of create a whole nother crisis and to have that cycle continuing to happen.
And we've seen, I know in working with families that we are working with, just your guys' turnaround has been really rapid. And
Mhm.
from the point that you joined the case to a really good placement, it felt like for one client so how quickly I'm sure it depends a little bit, but can you guys
Yeah.
be available and then help with placements?
We can be available pretty quickly from the time that we start our process, which starts with a consultation where we get medical records. We want to talk with you guys to get your clinical recommendations and your clinical experience with the family. I don't want to make recommendations to a client in isolation of all of this pertinent information that you guys have. But from that point of being able to gather all of the information that we need, that can take 24 hours,
Mm-hmm.
just giving us the time to have the opportunity to do the research so that we're making good recommendations. And then recommendations, we can have kids in treatment within 24, 48 hours if we're in a crisis.
Right.
If we're not in a crisis, we can slow that process down a little bit and allow for parents to have more of an opportunity to do a little bit more due diligence, more research,
Right.
and comparing and contrasting a number of different options. Sometimes it is needing to move that quickly. And always knowing, like, we're not going to make recommendations to programs that we wouldn't make, if we have the luxury of more time. There's still going to be programs that we have confidence in and that we've had success with.
So just for anyone watching this, we have Kim Jenkins information in our provider database, and her email information, all of her contact information. So I just wanted to kind of provide just a hint of that kind of service offering.
Mhm.
There's certainly a time when we hit that point, and it's so good to know that you guys are out there doing what you do.
Yeah.
So
Yeah. Thank you. It's fun and it's intense. And as you guys know, I know you guys work with a lot of clinical intensity as well. And so just being able to partner,
yeah.
um, and sometimes it's just even having a conversation, us consulting with one another saying, hey, like, what do you think about this case? And, we're happy to spend some time, with your clinical team if they have potential families that may be a good fit.
That
The
would be,
cost factor is something, I don't know if you want me to speak to that, Deborah.
yeah, why don't you give us a little hint of that? Because I know that is a factor. So everybody,
Yeah.
we're referring to clients who can afford this level of
Mhm.
service. So
Yeah, so it is outlined in the information I sent you. Our consultation, we charge $800 for all of that information gathering. And then most of our families will sign on with us for a year's worth of placement support and ongoing case management. So we don't just provide referrals and then send parents on their way.
Right.
We're involved every step of the way, usually talking to them every week, if not, every month. And our typical yearly contract is about $7,000. That can be variable depending on, there's nuances of cases where it might be a shorter term placement. We're not going to charge as much. If there's substantial clinical complexity, if there's a really crazy divorce situation, custody stuff, we may charge more just because there's sometimes court involvement and stuff like that. Insurance does not cover our fees because we're consultants and we're not serving as clinical therapists or providers directly to the clients. And then the programs that we work with are also, I would say many of them are private pay, will be a combination of private pay as well as insurance. Families do have to have the ability to have some resources in place.
Right.
So,
Right.
Yeah.
Okay. None of us can serve everybody, but the best we can do to serve those that we work with. So I'm going to end the recording for now, and I really appreciate you sharing your information. And I know we've had great success working with you with our clients, so I'm so glad to be able to spread the word about you guys. So I'm going to.
Yeah. And